Hi, I'm Dr. Romeo Bruni, and today we're going to discuss the dizzy patient. The dizzy patient is a very common presentation in the emergency room, and it's very important to be able to assess it. As usual in medicine, and especially in emergency medicine, I would say that the history is probably 90% of the diagnosis. So it's very important to get a detailed and accurate history. In order to get a detailed and accurate history, in this case, I think it's first important to know what the differential diagnosis is potentially, because you need to target your history based on that differential diagnosis. Most experts agree, and certainly I do too, that there's 4 basic types of diagnoses that are possible when you consider the dizzy patient. And if we look at them here, first, and I'll go into more detail shortly, first is vertigo, second is syncope and pre-syncope, third is disequilibrium, and a fourth is vague lightheadedness. If we look at each specifically, vertigo is very important. 50–60% of the cases will be vertigo, maybe higher. And vertigo means motion. That means the patient is either feeling motion, or the room is spinning, or there's some type of illusion of motion that the patient is experiencing. That's very important. Syncope and pre-syncope are when you're fainting. When the brain doesn't get enough blood flow, the brain only needs 3 things to work. It needs glucose, it needs oxygen, and it needs blood flow. So certainly low blood sugar can be a sign of, can present with a vague kind of dizziness, but it's usually easily diagnosed and doesn't usually confuse you. So assuming that the patient has oxygen and glucose, then the thing that's going to immediately lower their blood pressure will cause a patient to faint. This is when they actually faint, it's syncope. When you feel like you're about to faint and you don't actually faint, that's pre-syncope. So that's a general category. Obviously, a syncope can occur when patients are standing up quickly, because their blood pressure will drop when you stand up quickly. So vertigo, when you get the motion, syncope and pre-syncope when your blood pressure is dropping, disequilibrium. The mechanisms that the body uses to control equilibrium in the patient is more than just the labyrinthine system, which would be involved in vertigo, and involves the musculoskeletal system, the proprioceptive system, and all the peripheral sensations and inputs and feedbacks to the brain that are required to maintain a balance. So any of those, if there's disequilibrium, if there's malfunction, for example, if the patient has multiple musculoskeletal problems, if the patient has Parkinson's, if the patient has types of peripheral neuropathy, multiple sclerosis, combinations of these things, you'll also get a vague sense of being off balance, if you will, when you're moving and walking. And that is a separate category, separate from vertigo and syncope, obviously. And disequilibrium is usually going to be in older people, and often it'll be multiple things combining, slight peripheral neuropathy with various joint diseases, etc., so that the patient isn't moving as smoothly. The fourth category is a vague sort of category, which includes people who describe dizziness, but when you pin it down, it's more of a lightheadedness. It's not really very specific. And these are often, you can have this type of dizziness associated with psychiatric conditions. Of course, if the psychiatric condition causes you to have a panic disorder and hyperventilation in itself by drawing down the PCO2 will cause dizziness also. So very important then that you get a good and accurate history to try to pin down which of these four possibilities is most likely. If you're getting a definite sensation of motion in the patient and they're telling you that the head is spinning, then you start to look at the vertiginous problems and their differential diagnosis. If the patient's giving you more something that represents a fainting spell, then you're obviously going to be looking at the causes of syncope. So with your history, you have to pin down which of these four general categories you're working with. And then of course you can use your physical examination and some investigations to also help sort things out. So let's go into a little bit of detail. The history is very important. If you start to determine that the patient is describing vertigo, then you need to get, as like in all matters in medicine, you need to flush out the history. When does the patient get it vertigo? Is it episodic? Is it paroxysmal? Paroxysmal means it comes on suddenly and unpredictably. Does the patient have vertigo right now as we speak? Or is the patient fine right now but gets vertiginous episodes at some point previously? So you have to flush out all the particulars of the dizziness. I can't stress how important the history is enough. You never want to put words into the patient's mouth. You can't ask them up front, is the room spinning around? Hopefully they'll volunteer that. You ask them, what's the dizziness like? If they tell you they're dizzy, you don't accept the words dizzy from the patient. You ask them, please describe your dizziness in other words. So you try to get from them, oh doc, the room is spinning around and around. Well, that's obviously vertigo. Oh doc, I'm fine, and then I sit up and I feel faint and feel like I'm going to pass out. Well, then you're thinking syncope. So don't put words in the patient's mouth. Don't accept dizziness. But if they're continuing to be vague and continuing to fail to pin it down, then finally you are allowed to ask, is your head spinning? Is something spinning? If they say yes, that probably implies vertigo, but because you've implied it to the patient, there might be a little bit of, it might not be as good a history if you're putting words into the patient's mouth. Okay, so let's say you've decided that it seems or sounds like it's vertigo. If it's vertigo, based on the history, the main differential diagnosis would be then to distinguish between central and peripheral causes of vertigo. The central causes of vertigo are going to involve the cerebral cortex and especially the cerebellum. The peripheral causes, of course, are going to be involving the labyrinthine system and the semicircular canals, which help maintain orientation in space for a patient. So the majority of time, it's going to be a peripheral cause. It's important, however, to distinguish the central causes. Even though they're in a minority, they're very important to diagnose because serious consequences will result if you don't make the diagnosis quickly. So you need to be able to distinguish between central and peripheral causes. If the patient is describing a continuous vertigo and they arrive in the emergency room very vertiginous and lying down and not able to stand up, and they describe perhaps vomiting, nausea and vomiting, that is described as an acute vestibular syndrome. The patient is actively vertiginous at the time. Very important to sort that out accurately, because if you look at this sort of flow chart of the peripheral causes, vestibular neuronitis, paroxysmal benign positional vertigo, we'll get to that in a second, and Meniere's. These two are going to be more episodic. But vestibular neuronitis, which is an inflammation of the vestibular nerve, which is the nerve which carries the information from the labyrinthine system back to the brain, inflammation of the vestibular nerve is going to give you a continuous vertigo with nausea and vomiting. A cerebellar infarct, which is lack of blood flow and death of cerebellar tissue, is also going to give you acute vertigo and prolonged with nausea and vomiting. And it's possible you could have just vertigo as the presenting complaint in a cerebellar infarct. So these two, a cerebellar infarct and vestibular neuronitis can present almost identically. And so it's very important to distinguish between the two, and there is a very excellent physical examination that you can do to distinguish that, and that's called the hint exam, and we'll get to that shortly. But getting back to this, so once you've determined it's vertigo, if it's episodic and in children, then it might be a migrainous vertigo. Migraines can give you vertigo. In fact, migrainous vertigo is the most common cause of vertigo in children, especially. So a migrainous vertigo can present with a typical kind of migraine picture. You could get phono or photophobia or weird sensations, and then a headache, but vertigo can be a prominent complaint. Cerebellar infarct, it can present just with vertigo, but of course, because of the posterior circulation being involved, you can get other cranial nerves involved. You can get some long findings into the limb ataxias and whatnot if the midbrain is involved. So cerebellar infarct, in part of the history, obviously, you would be trying to elicit from the patient, have they had similar kind of things in the past, TIA kind of things. Hearing loss can be a prominent thing in infarct, and it can come and go. It can be a TIA, if you will. So to distinguish between a cerebellar infarct and vestibular neuronitis, which is both going to present with vertigo in the emergency department, you need to do the hint exam, and we'll be describing that shortly. If instead the patient's describing vertigo, but at the very time they're in the emerge, they're not vertiginous, and they say they get episodes of vertigo, but right now they're not vertiginous, then again, of course, you need to flush out the history. Is it happening in certain positions when they're in bed and not rising up? If it's just lying down and positional, well, then you can be diagnosing perhaps paroxysmal benign positional vertigo. This is actually the most common cause of vertigo presentation in the emergency room. And what happens in this condition is you have little calcium buildups in the inner ear, which, depending on the position you take, start to move and give the patient the sensation of motion. And it's actually a calcium buildup in the ear and can be treated very easily by certain maneuvers where you actually reposition the calcium buildup in the inner ear and move it into a part of the semicircular canal apparatus, the utricle it's called, where it doesn't cause this sensation of motion. So you'd be able to treat the patient, boom, just like that, and fix them up. Meniere's disease is often overdiagnosed. You get the quadrat or the triad of hearing loss, vertigo, tinnitus, and a fullness sensation in the ear. You get episodic episodes that develop over years. Any one of these three can begin first. It can be bi or unilateral, usually begins unilateral, so you get unilateral hearing loss in this condition with tinnitus, which is ringing in the ear, and of course the vertigo and the hearing loss. There is no specific physical examination you can do, unfortunately, and it's a difficult diagnosis to make and often overdiagnosed. So let's just do a couple of things. I want to demonstrate a couple of things with the dizzy patient, a couple of things you need to do with the patient. So remember, if the patient arrives in the ER and they're actively dizzy, then you need to do the hint exam. And the hint exam is three different things. It's the head impulse, nystagmus, and you test for skew, deviation of the eyes. And I have a very kind volunteer, Alina's gonna come over and we're gonna show a couple of these things. Alina, thank you for volunteering.
My pleasure.
If you sit down, and we can actually do this lying down. The head impulse test is really what we used to call the doll's eye in patients when they were unconscious. We would actually do this. And you ask the patient to just fix on my nose. And then you just tell them, just keep fixing on my nose, even though I move their head. Beautiful. Just like that, very gently. Keep looking at my nose, even though I move your head. Oh, and then you suddenly move the head in a position where the patient isn't expecting. And the normal response is the patient will still be able to maintain fixation. If the patient loses fixation and the eyes drift off, that's an abnormal reaction, and that indicates that something is malfunctioning in the peripheral system, because it's part of the reflex system that gets this, that coordinates this reflex. So if that reflex is not functioning, it's a sign of peripheral disease. So if you're thinking that the patient has vestibular neuritis, you would want to see an abnormal head impulse test. And if it's normal, that worries you because, hey, wait, why isn't this labyrinthine system malfunctioning if it is vestibular neuritis? And if it's not malfunctioning, that's a sign that, it could be a cerebellar infarct, or of course a hemorrhage, or any kind of like vascular disease of the cerebellum. So the head impulse test being normal would be a sign of a central disease in this case. And if I ask Selena to please sit up for me. And then the other two things you would be doing, of course, is a test for nystagmus. And the way you would test for nystagmus in the patient is you'd ask them to fix on the black tip, holding their head steady. You just move their eyes through a full range of motion, like this. And if you have nystagmus at the start, just like that, that's not a good sign. If you're moving their head around and when you move in this position, suddenly they have nystagmus, which is a fast jerking motion of the eye in that direction. And then you move it in this direction and they have nystagmus also. So the nystagmus is depending on the direction you're looking. That's a very bad sign. That's a sign of central involvement again. So you'd be testing for that. And then the third thing you'll be doing, excuse me for a second, is looking for skew deviation, where you'd ask the patient to fix on something across the room there. And then you'd cover one eye. And if there's central problems, that eye would go askew. You cover the other eye, meaning normally the eye should just maintain perfect alignment when looking into the distance. But when you're covering up one eye or the other, and suddenly the eye covered up starts to skew out of position, either skew up or skew down, abnormal skewing, that's also a sign of central disease. So if it's a sign of central disease, then you're worried about a cerebellar infarct. In fact, I remember once in my career having a patient I was very suspicious of cerebellar infarct because his vertigo was so profound. We actually did a CT scan. That was back in the day when I thought a CT could diagnose everything. The CT was negative, and we ended up sending the patient home. He returned 2 or 3 days later. He had, in fact, had a cerebellar infarct, but initially CTs can be negative. In fact, even MRIs can be negative, and that's why the hint exam is actually more sensitive at diagnosing central causes of vertigo than is even an enhanced MRI. So the hint exam in the patient with acute vestibular syndrome is vital and must be done and must be documented. In the case where the patient is describing something that sounds like benign positional vertigo, there you're going to get vertigo that lasts no more than a minute. It'll come out of the blue in certain positions that the patient takes, usually in bed. In those cases, when you get that kind of history, then you can be highly suspicious that that's what you have. And then, in that case, this is what you do. You would do what's called the Dixie-Hall pipe maneuver. And you get the patient, Lena, would just sit like this and stand up like this. Can you just put your feet out a bit, Lena? So, and then you tilt their head to 45 degrees like this. And then you bring them down in that position with their head tilted, supporting their head, obviously, and looking right at the finger here. And you'd be looking for nystagmus. If you start to see nystagmus in that position, that tells you that's that the diagnosis is correct, and the abnormal ear is the right ear on this side. Then you'd bring her back up, and if that was negative and you didn't see nystagmus, you'd turn the head on this side and come back down and come back about 20 degrees below. Again, looking for nystagmus on this side, a fast-beating nystagmus. And if you see nystagmus in this position, that tells you that it's the left ear that's affected. So let's go back up. Now, the maneuvers, unfortunately, aren't 100% sensitive for diagnosis, meaning you could have a negative Dixie Hall pike, and the patients could still have benign positional vertigo. So if the history is very compatible with the benign positional vertigo, you're best off just treating the patient with the maneuvers, the Dixie Hall pike or the Epley maneuvers. They've also been known as Barani maneuvers, numerous names to them, and I'm going to show you how it's done. Let's say you've diagnosed that the affected side is the right side. So you'd start with the patient to reposition the calculus. You'd start the patient with the head turned like this, and then you'd bring them down, and you'd hold them like this for for about a minute, 30 seconds to 60 seconds. If there's nystagmus, you wait for the nystagmus to end, and then you'd get the patient to shift like this and hold their head. You'd shift 90 degrees to the other side, and you'd hold this position for about 30 to 60 seconds. And then in the final position, you get the patient to turn another right over sort of onto their stomach, come right over. And so you shift another 90 degrees, and you hold their position like this for another 30 to 60 seconds. It's kind of hot in here, so I won't make poor Alina, sit in those positions for very long, but basically you're going to come down here, 30 seconds to a minute, 90 degrees, over 30 seconds to a minute, and then a further 90 degrees, for 30 seconds, sorry, a further 90 degrees for the further 30 seconds to a minute. And hopefully you're going to take that little piece of calculus and shift it out of the inner ear, out of the semicircular canals, and into the utricle where it won't cause problems in the future. And you may be able to cure a patient, boom, like that. Thank you, Alina. You're free. I know it's hot. Thank you so much. So let's go back to our board here, and we'll just finish off. So again, get your history, very important. Try to pin it down, vertigo, syncope, disequilibrium, or a vague psychiatric thing. If you don't think it's vertigo and you start to think about syncope, well then of course syncope is a very important cause. There's many medications that can give you orthostatic hypotension, which means when you sit up quickly your blood pressure drops, and that's going to give you a kind of dizziness. For that, the appropriate physical examination is orthostatic blood pressure measurements, meaning you either start the patient lying down or sitting up and measure their blood pressure, and then you quickly stand them up and measure their blood pressure. And let's say they're sitting down, the patient's blood pressure is 150 over 90, and then you sit them up quickly and their blood pressure goes to 120 over 70. Well, that's too low. The blood pressure's dropped too much. The blood pressure should not drop more than 20 systolic and 10 diastolic. If it starts to drop more than that and the patient starts to describe symptoms at that point, well, then you've diagnosed orthostatic hypotension. Medications are a very, very common cause of orthostatic hypotension. But it can be more than just orthostatic hypotension, of course, that can give you syncope. If you go back to, remember what we said about the brain needing just blood pressure, glucose, and oxygen. The blood pressure, a patient's blood pressure is determined by the cardiac output, how much blood the patient's pumping out, times the peripheral resistance. If the peripheral resistance is higher, it makes the blood pressure higher, so it supports the blood pressure. So if peripheral resistance drops too much, that can give you a cause of low blood pressure, often related to medication. But also if the cardiac output obviously drops too quickly or too much, that can give you low blood pressure. And cardiac output is the heart rate, which is the number of beats per minute, times the stroke volume, which is how much blood is being pumped with each beat. So the cardiac output is the heart rate times the stroke volume. So abnormalities in either of those two can give you syncopal episodes, especially if you think of heart rate. If the patient goes into an inappropriate bradycardia, that means the heart rate is going too slow, then you'll get decreased cardiac output and can get dizziness. Or if the heart rate goes very, very fast, if it goes too fast, it can't fill up properly. So even though the heart rate is increasing, because it's not filling up properly, it's pumping very little blood each time, so the stroke volume is decreasing. So that's another reason the cardiac output would go down. Of course, if you suspect that they're going through abnormal tachy or bradyarrhythmias, and they can come and go spontaneously, that's when you order what's the ECG and a Holter monitor. A Holter monitor is like an ECG that you wear for 24 or 48 hours, constantly monitoring your heart rate, so that if you develop an abnormal heart rhythm, you'll be able to diagnose it on the Holter. It'll actually show, oh, look, for 5 minutes between such and such a time, the patient's heart rate jumped to 180. They would have some sort of abnormal system in the heart causing them to go into fast heart rate. So you need to assess the patient for syncope. So that's good. We've covered a lot of ground. Let's just summarize quickly. Like everything in medicine, the history is at least 90%. I'd say physical examination 5%, investigations 5% of the time lead to diagnosis. 90% of the time it's the history. So take the time to get an accurate history, develop from the patient. When do they get dizzy? What does it feel like? How does it feel? How do they reproduce it? What makes it better? The more information you can get from the patient, the better, because it's the history that's going to help you to pin it down into one of these 4 major groups. Then for physical examination, if the patient's not dizzy and it's episodic, then you're going to be doing Dixie, Hallpike, and Epley maneuvers. If it's a continuous dizziness and the patient's quite incapacitated, then you have to do the hint exam. You never do hint exam on a patient that's completely normal, and you wouldn't do a Dixie Hallpike exam on a patient who's in an acute vestibular syndrome, because any patient that's in an acute vestibular syndrome is going to be worsened by moving their head around and doing Dixie Hallpike. So it's completely inappropriate to do Dixie Hallpike in patients who are presenting with acute vestibular syndrome. So hint exam, Dixie Hallpike, orthostatic changes. This is how we usually document it on the chart. You show the patient sitting and their blood pressure, and then you show them standing up and their blood pressure. Often you'll also take the heart rate, because the heart rate should go up a little bit, but not a lot when they stand up. So get your history, how, when, what makes it worse. Is it continuous versus episodic? Be sure to get all the medications when you do your history. Medications routinely cause either orthostatic hypotension or some disequilibrium issue. And then make your diagnosis and treat the patient appropriately. Dr. Romer Bruni, I hope you enjoyed this. Have a great day.